Hey everyone, I'm Jessica Kramer with MRC-TV. Today we're speaking with Dr. John Bruchalski of Tepeyac Family Center, a former abortionist turned Catholic pro-life doctor who runs one of the largest life-affirming medical practices in the country, to discuss the disinformation about abortion that's being pushed by the media after the recent Dobbs decision. Dr. Bruchalski, thank you for joining us.
Oh, Jessica, thank you so much for the invite and the opportunity.
So there's lots of disinformation coming out regarding miscarriages, equating them to spontaneous abortions. We wanted to give you the opportunity, this may seem ridiculous to some of our viewers, but can you explain the difference between an abortion and a miscarriage?
Sure, absolutely. And it all has to do with language, as well as procedure, as well as medical reality. So it's all three of those put together. So, as we all know, history creates words in order for those words to create history, right? So when Roe was legalized, when it became law of the land, they were talking about an elective abortion, Jessica. That means I, as doctor, want to end the pregnancy, end the life of the child inside mom, period. That's what I was asked to do. And I need to do it to the best of my ability. And the outcome of an elective abortion is not only an empty uterus, but it's also the death of the child and that wound inside the heart of the mom and the family. Because abortions are really never, elective abortions are very rarely ever desired for empowerment. They're mostly done out of fear. I don't have many other options. And that's what I hear. That's what I've heard for the last 30 years. Because I learned this from listening to my patients. So what we're talking about here is elective abortions. That's what Roe was about. We called it the voluntary interruption of pregnancy, VIP. We used to put it on the board so people did not know the word abortion would not appear. Abortion is so stigmatic. It causes so much pain in the heart, and it's so associated with back alley. And I don't mean illegal. Even doctors who do abortions today don't really come out and say, yeah, I do abortions. Why? Well, they say it's because of violence. I actually think it's because it's still considered by the vast majority of people to be not a part of the healing art of medicine, right? And so this battle goes back and forth. Oh, it's an abortion. Well, a miscarriage is also considered an abortion, but not an elective abortion. So when you remove the word elective, oh my gosh, I would never tell a woman with a wanted baby that she just had an abortion when I could use the word miscarriage. Our patients are looking for excellence in healthcare. They're looking for a language of love and compassion, and also a physician who they can trust to give them good advice. Because I can drive, when I was on the other side of the abortion issue, I did abortions the first 2 years of my residency, and I encouraged them the last few years of my medical school training. So that was 7 years out of about 40. Now, if the woman looks at me and says, well, doctor, what should I do? Well, your baby may have this condition and you're going to suffer and the baby's going to suffer. So therefore, I would recommend X. Well, that happens every day across this country whenever there's a miscarriage or an ectopic. So let's kind of get to some of those. A threatened abortion is when a baby is miscarrying. The big difference there is that the mom doesn't want the miscarriage to happen. With an elective abortion, of course, she wants the end of the pregnancy, even though it may be tearing her up inside. Maybe it doesn't, but that's what we see. So an incomplete abortion is like an incomplete miscarriage. The baby and the tissue, the bleeding, the cramping start. And for any one of our audience who has had one, oh, Jess, this is huge. They're in tears. What did I do to, real mothers, what did I do to cause this? Well, I want to tell them that if everything but cocaine, I'm kind of not teasing here, but if you're not doing cocaine, you're not causing the abortion. Well, what about the worry? What about an argument? What about violence to women, a punch, a kick, the craziness that we have today, that might do it also. That's why we always ask about intimate partner violence, something that I don't think they're even asking on the medical abortions they're recommending these days. So once again, an incomplete miscarriage is when some of the stuff is still left inside, usually the placenta, and also for our audience who's pro-life, a D&C, a dusting and a cleaning, as my mom told me. No, a dilation and curettage. It's the same procedure as an abortion. So a lot of my moms are like, oh no, John, please, I don't want the surgery. That's an abortion. No, it's not. The baby's already dead. And if there's a hemorrhage going on, we go after the disease, not the baby. We go after what's causing the bleeding. It's not the baby, it's the placenta. So really good life-affirming medicine always differentiates between the two. And remember, abortion is a word of the shadows. An elective abortion is a word of reproductive health.
That's what we're talking about, is respect, freedom of reproductive health.
Reproductive health.
Reproductive health care.
For women.
That's a euphemism for abortion on demand at any time for any reason. Wait a second. Excellent life-affirming care can take care of two patients, both mom and baby. And the words matter. In fact, words dictate history, right? So once again, that's kind of the foundation. Now let's just go to a miscarriage. Miscarriages, 95% of the time, more even, there's no fetal heartbeat. So once again, if there's no heartbeat, it's not an abortion, it's a miscarriage. You can call it a incomplete abortion or a threatened abortion in medical parlance, but it's like putting the name to your unborn child. Oh, it's a fetus. Oh, it's a blob of tissue. Oh, it's nothing. It's this language battle, because in order to get mothers to really end the life of a wanted, loved pregnancy, even an unwanted pregnancy, you got to start distancing psychically and medically between head and those incredible 18 inches to the maternal heart, right? And so, boy, it's so different, so radically different that it breaks my heart to see. Last night, I took a question from a patient and a mom who said, but isn't it the same procedure, doctor? Isn't it just an abortion? No, it's not. And so once again, we really are, I don't know why they're doing it. I would assume that they're trying to confuse and try to continue this farce that elective abortion is healthcare. What I'm here to tell you and help you with is just the opposite, is just something else.
Yeah, I mean, we saw it. Yeah, we've seen it recently going on in Congress, all the debates happening right now, all the hearings. There's a lot of disinformation being spread, especially about ectopic pregnancy treatment. So we wanted you to explain, what is an ectopic pregnancy and what is the correct course of treatment?
So, I'll do my best. When the egg and sperm come together in the fallopian tube, that's the highway between the ovary and the womb. When it comes together there, it tumbles down the tube into the uterus where it implants naturally, normally. An ectopic is because there's some sort of damage in the tube, that little unborn child, that blastocyst, gets caught and then grows there. That lining in the tube, that highway lining, is not good for health or nutrition. And that baby begins to grow. Usually, we see most ectopics identified between 6 and 8 weeks. That's when they can rupture at 6 to 10 weeks. But once again, because science has evolved over the 50 years since Roe, you have a baby growing, an unborn child growing in the tube. 90+% of them, the baby's dead. So guess what? You can do anything you want, surgery or medicine. Now, if there's a heartbeat, and you do not want this to rupture because that's a life-threatening condition, as a doctor, I treat the diseased tube. We go in surgically with minimally invasive surgery, which we're doing for everything nowadays, and we remove a section of the tube. So we're treating the disease, not the baby. And so that's really
or
where
treating the baby
conundrum-
as a disease.
Right, because, in my other life, children were sexually transmitted diseases that needed to be treated. Well, that's not quite the way it works.
I wanted to lead into, you had a conversion that changed your ethics in medical practice. What is the pro-life ethic when you have a pregnancy that could endanger the life of the mother?
So that's the heart of the issue here, because and it's real. Don't get me wrong, it's real. So you never pit mom against baby. That's one of the first foundational issues. Number two, you always treat the disease. You never treat the person with that disease. Okay? Three, as an OBGYN, you always treat two patients with life-affirming medicine and get them as far along as possible. Our intent is to birth the best, healthiest baby we can, or if the child has severe anomalies that the world says are incompatible with life, well, at the time of diagnosis, they are alive. And on top of that, we turn the womb into a perinatal hospice. So from our point of view, we get them along as far as they can, because all the risks, you know how some of our people in our work environment would stay home if they had a little sniffle. Maybe they thought they had COVID. They want to be, well, there's other people who kind of go, no, I don't have a fever. I've got allergies. Well, both of those people are dealing with the risk of a very serious condition. Now, it's the same with pregnancy. If I say that this pregnancy can turn into a problem because you have hypertension, you have kidney disease, you have lupus, you always care for two. And now we have the medicine and the technology, even though some people have difficulty with technology, they get it far enough along so we can deliver a baby after viability. Let me tell you one quick story about Blue Betty. I'm in a Catholic hospital in my residency, and down the hall, a nun is escorting a patient by the name of Betty, who's absolutely blue, almost as dark as your blouse, as your top. Not quite, but it's not a pretty blue. It's a dusky blue. It's the blue of an anaerobic bacteria. The oxygen is low, the carbon dioxide is high, and she's in trouble. She had no diagnosis before this. So I'm like, we need to end this pregnancy to save her life right now. Well, we don't do that here at this Catholic hospital. What do you mean you don't do this? Are you archaic? Are you medieval? That's the most stupidest thing this is ridiculous. Well, we transferred her once we stabilized her at the clinic to the big house, to the big medical center. We stabilized her in the ER and we took her back to surgery and we aborted her. The baby died and so did she. We never once at that whole time tried to look at the woman in her totality. Yes, she needed delivery, but my God, she didn't need an abortion at the time. And by God, she needed more care for her pulmonary hypertension. Now, there are difficult cases, but if it's before viability and you have something like this, you treat the disease. So if the woman's water breaks early in pregnancy and a uterine infection is one of those conditions that can threaten the life of the mother, is she threatened at that moment? Can you do anything to prolong it? Well, just yesterday, I came back from a home visit because we had a mom whose water broke at early 15 weeks. Every hospital, every doctor she initially went to said, end it, it's too risky. Well, in conversation, we just simply said, well, take your temperature, we'll check some blood work. We'll make sure we have good technology now. We have good lab tests. We'll make sure you don't get infected or at least catch it early. Well, lo and behold, guess what? The little one was born at about 4.5 pounds, almost 5, at 35 weeks. Totally okay, back at home with its mom. Now, once again, you can't say everything works out that rosy, but I can sure tell you that when you care for two patients, both mom and baby, to the best of your ability, and counsel them that, yes, this is a life-threatening condition, but you're not there now. And we're not going to wait until you're almost dead either. We're not going to do that either. We're going to C, if the infection creeps in, we deliver the diseased placenta that happens to have the baby in a sac right next to it. And those are the worst, hardest, difficult cases, but it's not an elective abortion, period. So with life-threatening disease to the mom, how close are we? Is the woman experiencing any one of those signs of a bleeding ectopic, an infected uterus, or maybe the medical problems with lupus or severe seizing or any number of conditions? But today, because of modern medicine, Jessica, I want to tell your audience, we can help both patients. And that's the intent. There's always two. And you never kill the baby to save the life of the mother. You never even, it's an unwanted side effect of caring for both, because even after the abortion, the woman is still left with, "Can I really decide this?" It's a matter of the heart at that point.
Yeah. I think a lot of the crux of this issue comes down to intent and heart and, like you said, language. So thank you for clearing that up and giving us your expertise. And after decades of delivering babies, I mean, we really appreciate it.
Oh, please, you're so welcome. And I'm glad that my experience can be used for good. Thank you so much.
Thank you.